All right. Good afternoon, everybody, and thank you for attending this session of Grand Rounds. I'd like to welcome our presenter for today, Dr. Elena Swingler, who will be presenting on the topic of non-tuberculosis Mycobacteria infections. At this time, I'm going to stop sharing my screen and turn the presentation over to Elena.
Thanks, Chelsea. Give me a second to share. Okay, can you see my screen okay?
We can see it.
Great. Okay, so thanks for attending, everybody. So today I'll be picking up where Dr. Junkins left off last week. So he was talking about how we identify mycobacteria in the lab. And specifically, I want to focus on non-tuberculous mycobacterial infections, or as I will refer to them as NTM. So Mycobacterium as a group, as a genus, has more than just NTM in it. So NTM is just one of the categories. And other Mycobacterium include Mycobacterium tuberculosis, or TB, which many of us are familiar with, and Mycobacterium leprae, or leprosy as well. But today we'll be focusing on just the NTM group. Now, just because it's one group doesn't mean it's small. There are over 190 species in this group. And like Dr. Junkins said, they are different from normal bacteria. And when we say normal, what we mean is it's not like our Staph aureus or E. coli pathogens that we usually encounter in the hospital. So these are acid-fast bacilli, and basically what that means is they're not gram-positive or gram-negative organisms. That's not really how we classify them. They need a special stain for us to identify them. So we really got to look for them in a special way. The other way they're different, like you mentioned last week, variable growth times, but in general, they're very slow growing bacteria. So there are some subsets that are faster than others called rapid growing mycobacteria. But this is a little deceiving because they're still slow. They can take up to 7 days, even for the rapid growing bacteria. And other species can take weeks to months for a full identification and susceptibility. So for the natural habitat of NTM, they can be found in soil, water, dust, animals, really anywhere in the environment. Community tap water is a major reservoir. So there's organisms, living in that biofilm in water that's not decontaminated. The key thing I want to point out with NTM for transmission, so environmental transmission, like from water or just the environment, is the most common route of transmission. This is generally not considered to be a contagious infectious disease. So this is very different from tuberculosis, because we know with tuberculosis, we are very much concerned about contagious pulmonary TB. So why are we talking about NTM today? So NTM as an infectious disease has gained traction and popularity over the years for several reasons. It first recognized in the 1930s to be a human pathogen, and then it really gained more attention in the AIDS epidemic. So patients with AIDS are severely immunocompromised, and we saw in those patients Mycobacterium avium complex, or MAC, serious MAC infections, many times disseminated. So that's where this interest kind of began. But then since the epidemic, we didn't really see NTM go away. Instead, now we're finding it more in non-immunocompromised patients. Also, they have been associated with healthcare-associated infections. And the other kind of point of interest is the treatment of NTM has a relatively low treatment success rate. And the quality of evidence that guides our management is not very good. So it's a very challenging disease state to treat sometimes. And I'll talk a little bit more about that later. But and then also increasing incidence and prevalence. So as a disclaimer, it is pretty difficult to estimate the exact burden of NTM disease. Some reasons for that are it's not mandatory to report NTM infections to any agency. It's also difficult to pinpoint whether an isolated pathogen is a true infection versus a contamination or colonization. But overall, the trend of NTM is increasing, so incidence and prevalence, as you can see in these graphs from a large health insurance database. Some reasons for this, we're improving our lab techniques, so identification of these organisms is becoming easier and easier, and we're, we find when we look for them. Aging population, medical advances, certainly more and more people are surviving to old age, and they have various ailments and comorbidities. So we really have kind of a bigger pool of hosts for this infection as well. So what kind of infections does NTM cause, and where are those infections in the body? So pulmonary or the lungs are the most common site of infection, and Mycobacterium avium complex, or MAC, is the most common one we see here in the US and pretty much worldwide. Because of that, I'll kind of be focusing the rest of the presentation on pulmonary and a little bit of MAC management as well. But other infection sites include cervical lymphadenitis. So this is basically like a lump on the neck. It's usually painless, usually in young children. It's identified and sometimes requires surgery. And then bone, joints, skin and soft tissue infections are pretty common as well. This is particularly usually due to direct inoculation. So either patient has some sort of trauma, they have a surgery, injection, maybe a tattoo even, so contaminated kind of introduction into those areas. And then disseminated infections, like I briefly mentioned before, this is mostly seen in very severely immunocompromised patients, such as AIDS patients. So this is not something we see routinely whatsoever. So on this next slide, I want to show you the interplay between the different factors that are responsible for NTM infections. So we have the host, the environment, and the organism, and they all play a role in whether or not somebody gets an infection. So if we look at the host, some risk factors, I'll focus on pulmonary here, for getting NTM infection include structural lung damage or lung disease. So this can be things like COPD, cystic fibrosis, bronchiectasis, bronchiectasis being kind of widened, damaged airways that produce lots of mucus and lack of clearance of mucus. Also previous TB infection, actually. So patients who have had TB in the past usually have damage from that. They can be more susceptible to NTM later. Also, postmenopausal women and elderly women are particularly at risk. The reason for this is not entirely clear, but this population is at higher risk than others. Immunocompromise in general, obviously, is a risk factor, and then genetic predisposition as well. And we're only now beginning to learn kind of what that means. So environment, so for the environment, we have to get introduced to the organism, right? So like I mentioned, any contaminated water sources. So this can include like shower heads, for example, with contaminated plumbing, showers, create a perfect way for disseminating that NTM into the nice hot shower, steamy environment where the patient can breathe that in. Hot tubs as well could be sources, gardening, soil exposure, like I said, surgical and medical equipment, such as dialysis machines, and then geographic location as well. So certain areas of the world have certain NTM that are more common there than they are in other places. Here, for example, we have MAC, which is the most common. It's usually the most common everywhere else as well. But then also we have M. abscessus, whereas, for example, in Canada, they have M. xenobii, and that's their kind of second most common NTM. For the organism itself, So there's a spectrum, right? So there's 190 organisms in this group, and they're not all the same. Some organisms, if you isolate them, they're probably contaminants. M. gordonii and mucogenesium tend to be contaminants if isolated. However, some on the other end of the spectrum, M. kanzesii, those are more likely to be pathogenic if they're isolated. So this is always important to keep in mind. So now I'll focus here on exactly how we diagnose NTM, because it's not as simple as having, the organism grow on the culture. So to start off, possible presence of NTM infection should be considered in any patient that has chronic pulmonary infiltrates on chest X-ray and persistent symptoms. So symptoms of NTM include chronic cough. Almost all patients have a chronic cough. But then after that, it gets kind of unclear, because some patients may have sputum production, some may not. Fatigue is usually universal. Dyspnea, fever, potentially weight loss. But not all of the patients that have NTM infections have all of those symptoms. It's very nonspecific, right? A lot of things can cause these symptoms. It's not NTM. So besides the symptom, you have to have radiologic evidence. So radiologic evidence includes chest X-ray or CT that shows nodules, shows cavitation, basically kind of thick-walled gas-filled spaces in the lungs, bronchiectasis, again, kind of damaged airways. So you got to have one of those things as well. But that's also not very specific either. So we really have to exclude other diagnoses before we make a diagnosis of NTM. So patients that have this should be worked up for other etiologies like fungal, for example, pneumonia. Microbiologic evidence, obviously the big piece of diagnosis. The important thing here is the guidelines are very clear about sputum culture has to be positive twice. So basically in the initial evaluation, the patient will usually get 3 sputum cultures to evaluate for this, and 2 out of the 3 must be positive to have a strong suspicion, because if only 1 is positive, that could be transient contamination from the environment. Now, if we were going really deep in the lung, getting a bronchial wash, or a biopsy, this is obviously a little more invasive and going to give us a more accurate specimen. So only 1 of those can be positive. But basically, the moral of the story is NTM on a culture does not necessarily mean NTM infection. So let's look at pulmonary MAC infections. So if we diagnose NTM infection, the patient meets all those diagnostic criteria, and we decide to go forward with treatment, how do we go about doing that? So the example here shows the guideline recommended management. So the guidelines kind of categorize MAC infections into 3 different categories. So we have nodular bronchiectasis, we have cavitary, which is considered more advanced, more progressive form of the disease. And we have refractory. Refractory basically meaning you have failed the initial course of therapy. So for nodular, if we look at all 3 of these, we can see right away that 3 drugs are necessary no matter where you go, right? So no matter how mild or severe the disease is, you're going to have at least 3 drugs, maybe 4. So for nodular bronchiectatic disease, we can get away with dosing those drugs 3 times weekly. For the other more severe forms, daily administration is required. And the drugs themselves, azithromycin, rifampin, ethambutol, are the #1 recommended. There's some others within the classes like clarithromycin or other rifamycins that can be used, but those are generally what's used. And then those are recommended for all of those categories. But when we get to the more severe disease like cavitary and refractory, we need to start considering the possibility of adding IV amikacin, which can be dosed a little bit less frequently than daily, but that's an option. And then for refractory, Inhaled amikacin is recommended, potentially in lieu of the IV amikacin. There was a recent randomized controlled trial that approved an inhaled amikacin formulation for refractory MAC. So monitoring, so patient gets started on all of these medications, right? Now we have to monitor them. So patients are monitored by getting sputum cultures every 1 to 2 months, watching for sputum conversion, as we call it, or the sputum turning to negative. And then chest x-rays are going to be done periodically, possibly CT, also labs, just to evaluate for antibiotic toxicity and the antibiotic levels, such as with aminoglycosides, and symptoms. So definitely monitoring symptoms throughout this whole thing. So for antibiotic duration, we're looking at least 12 months of therapy from negative sputum culture. That is the recommended duration. Now, this is very long, and this is from negative sputum culture, so this isn't even the full course, right? Usually people convert within the first few months, but we're still looking at about 15 to 18 months of antibiotic therapy for full completion of the course. So now that we talked a little bit about that example, I want to go back and highlight some key principles of management. So macrolides are the key to a successful regimen for most common NTM infections. Macrolide class includes azithromycin or chlormithromycin. Usually azithromycin is used because of less drug interactions and better dosing schedules, but we know that higher failure rates are seen when macrolides are omitted from the regimen. Sputum conversion rates can decrease from 80% to about 36% for macrolide resistant MAC infection. And we want, the negative sputum to occur because that will predict success rate overall. High mortality with these patients as well. Unfortunately, we don't have good comparative studies of NTM regimens, but in general, there is higher mortality in patients with resistant macrolide infections. Now let's talk about some situations where macrolide can't be used. So some situations include inducible resistance. So some NTM have ERM genes. ERM genes are naturally present in some, and they encode for inducible macrolide resistance. So this is not all NTM, but some. So M. abscessus, subspecies abscessus, M. fortuitum, and M. smegmatis all have the ERM genes. So right off the bat, if we send the isolate out and we do this test, we can do a test for this, and it comes back positive, macrolides are out, can't use them. Acquired resistance is different. So acquired resistance happens during treatment, usually because of inadequate dosing or inadequate other medications in addition to the macrolide. So this is mutation that occurs. So for this reason, we saw with pulmonary MAC, we need 3 drugs minimum to make sure this does not occur, because this is one of the goals of therapy, is to prevent macrolide resistance. It also matters which specific antibiotics are used, because some do protect against resistance, some do not. So 2 drug combinations have been somewhat investigated, and there's some interest in this, but are currently not recommended, and there is still trials underway. So now I want to take a step back from talking about how we treat NTM infections and discuss briefly on whether we should treat NTM infections. And I know you might be thinking, well, we just talked about all of these things related to treatment. Why wouldn't we treat this infection? So unfortunately, it's not that simple. NTM is not like MRSA pneumonia, where it's pretty clear that if we don't treat that, the patient's going to get worse fairly quickly and decompensate from acute infection. So with NTM, we're faced with, the dilemma that this is a very slow, progressive disease, and there's really a lack of clarity around the risk versus benefit. And the guidelines say that even patients that do meet diagnostic criteria In general, it's recommended to treat those, but it should still be individualized decision. So we have to take all of these factors into account. Severity of symptoms, how pathogenic is the organism itself, the goals of therapy, patient preference is very important considering they're potentially going to be taking this for a whole year or more. Likelihood of success and risk of therapies, I will expand on a little bit next here. So the definition of success matters for NTM. There's a lack of consensus in the medical literature about what success really means. You could look at success in different ways. Microbiologic, for example, which is most commonly used, is a negative sputum culture at 6 months, because this has predicted to be associated with favorable outcomes. So that's kind of a surrogate marker for success. Durability, so how does the patient have a relapse after they have a negative sputum culture? So that's another point of consideration. Radiographic evidence, is the chest radiograph improving, clinical or symptomatic improvement, quality of life, and mortality, which is a lot more difficult to identify any benefit there. So just to give you an idea of some different success rates for pulmonary NTM. So in MAC, we have 60 to 90% sputum conversion. It's not great, but it's not terrible. However, with MAC infection, there is a high rate of relapse of about 50% of patients who get cured will subsequently have either another isolate grow or another diagnosed infection. Pulmonary hygiene alone, notably, is successful in some cases of mild infection. So patients don't even need antibiotic therapy, and they can just really improve the way they clear their airways and get rid of it that way. MCONSACI, on the other hand, 80 to 100% sputum conversion and a fairly low relapse rate of 5%. So you can see how this might be more kind of tipping the scales toward benefit for treating this infection. And then M. abscessus, subspecies abscessus, only 33% sputum conversion. Remember, this is a macrolide resistant isolate usually, and because of that, we have poor conversion rates. So another way to discuss risks of therapy or risks associated with treatment is looking at risks of therapy. So adverse drug reactions are very common. These patients are going to be taking multiple antibiotics for a very long time. So over 90% of patients have a reaction of some sort. Now, not all of them will be severe. However, up to 40% of patients will not complete treatment due to an adverse drug reaction. So it's very possible that the treatment is not successful, not because of the organism, but because it's just too much for the patient to tolerate. There's many different reactions possible. I won't list all of them that are written here, but the one I wanted to draw attention to is IV aminoglycosides for NTM. So when an IV medication is required, when we need to intensify the regimen, this is usually the next step. Sometimes in the hospital, we joke about IV aminoglycosides causing, ototoxicity or nephrotoxicity, as these are very real side effects of aminoglycosides. However, in the hospital setting, patients usually receive a dose or two, maybe a week of this therapy, and the tolerability is usually pretty good. However, for NTM, it's a different story. So for NTM, patients are taking IV aminoglycosides for a long time. So studies have shown that 32% of patients had permanent hearing loss as a result of IV amikacin for NTM infections. They saw that risk increased with age, increased with duration of treatment, and cumulative dose. Interestingly, nephrotoxicity was not a big factor here. It was generally mild and short-lived, but it was really the ototoxicity that limited treatment. So to bring this all together, let's look at just a couple scenarios, patients with NTM infections. So first, we have a 45-year-old male with a history of smoking, COPD, frequent hospital readmissions, and a new diagnosis of cavitary MAC disease. Should we treat this patient? I would say he does fall more on the would probably benefit side. For someone like him, he's relatively young, so he'll probably tolerate treatment. He has frequent hospital readmissions, assuming from COPD, so he's very symptomatic. And cavitary MAC is more progressive form of the disease, so he likely probably would benefit from treatment. On the other hand, we have this 80-year-old lady who has a late-stage lung cancer diagnosis and also a new diagnosis of Mycobacterium abscessus, subspecies abscessus, with the ERM41 gene detected. So that means that her isolate is macrolide resistant, and unfortunately she would require IV amikacin, IV imipenem, linezolid, and clofazimine for treatment of her infection to start off with. So that particular species is very problematic to treat, as I mentioned before, very low success rates for sputum conversion. And in somebody like her, she's elderly, she's probably going to have a lot of side effects from all of those medications. And with her late stage lung cancer diagnosis, it might not be worth the risk. But these are conversations that need to be had with these patients about NTM. So with that, let's wrap up by talking about infection prevention. So like I mentioned before, NTM is becoming more and more relevant in terms of healthcare associated infections. Community and healthcare associated outbreaks have been described, largely related to water system contamination. In addition to that, surgical contamination is definitely possible. So there can be all sorts of ice machines and other like dialysis machines and heater cooler devices and cardiac surgeries that can be contaminated and have all been reported on. For example, this heater cooler device situation happened during open heart surgery for patients. There was NTM that contaminated the instrument during manufacturing. And because the isolates take so long to grow, it wasn't until months or potentially even years later that some patients were identified to have been infected, probably due to this. Instructions from the CDC regarding NTM are not very robust, but they basically say to establish water management systems and programs that, the things that will take care of other pathogens like Legionella, for example, will also take care of NTM. They say to follow state and local reporting requirements for NTM. Now, Kentucky doesn't have any requirements to my knowledge, but some states or jurisdictions have, with higher incidence, have instituted some requirements. And they say to consider conducting surveillance for extrapulmonary NTM. So some maybe skin, bone, maybe disseminated disease, which is more likely to be associated with procedural things. So with that concludes my presentation. What questions can I answer?
All right, if there's no questions from the group, and always feel free to send me your questions if you have any after the presentation concludes. I just want to thank you, Elena, for this wonderful presentation, and say please join us next week where Dr. Ashley Wild will be discussing topics in antimicrobial stewardship. I look forward to seeing everybody then. Thanks so much.
Thanks.